Table on my far right is Dr. Fran Storrs, member of the program committee and professor of dermatology at Oregon Health Sciences University. She will ask the first question of our speakers today. The second question today will be asked by Gary Harrell, member of the Human Services Standing Committee of the club. As you know, we open the meeting up to questions from City Club members in the audience after our presentations from our speakers. Written questions will be asked as time permits. A microphone will be available. You see it there in the middle of the room for those that have questions from the floor. For those with written questions, forms are on the table, and please hold them up after the speech so that the staff can gather them and bring them forward to the table. And now to today's program. Today, the City Club hears from speakers on one of the most controversial topics in America, and indeed globally, the question of assisted suicide and the right to a humane death. This issue, with all its moral, legal, and medical ramifications, is squarely before the public, arising largely from the continuing activity of Dr. Jack Kevorkian in Michigan as he assists a growing number of persons in ending their own lives and tests the laws written to address the questions he's raising. Our speakers today are especially well-versed to help us understand what's at stake. Until his retirement last year, our first speaker, Derek Humphry, was the executive director of the Hemlock Society, an organization now of some 58,000 members. The society has been the driving force behind several attempts to reform the law to achieve physician-assisted dying for the terminally ill. Before forming the society in 1980, Mr. Humphry was a journalist with both the London Sunday Times and Daily Mail in England, and an author. In 1972, he won the Martin Luther King Memorial Prize for his contribution to racial harmony through his book, Because They're Black. He was motivated to form the Hemlock Society after publication of his 1979 book, Jean's Way, about the death of his first wife. Mr. Humphry remains most active as writer and lecturer, having just issued his new book, Lawful Exit: The Limits of Freedom for Help in Dying. He is a vice president of Americans for Death with Dignity, an organization that has targeted California for law reform by 1996 in this area. Our second speaker, Dr. Susan Tolle, is a practicing internist and serves as director of the Multidisciplinary Center for Ethics in Healthcare at Oregon Health Sciences University. She has played a key role in the development of ethics teaching in the schools of medicine, dentistry, and nursing at OHSU. Her special interests focus on the enhancement of humanistic communication skills in the provider-patient relationship and the building of outreach educational programs for practicing physicians, dentists, and nurses. Dr. Tolle is a member of the American College of Physicians Ethics Committee and of the recently formed Ethics Committee of the Society of General Internal Medicine. She has published over 50 articles and is frequently interviewed about ethical issues in healthcare, including euthanasia and physician-assisted suicide. Please help me welcome our two speakers to the podium today. We'll begin with Derek Humphry.
Good afternoon, ladies and gentlemen. Thank you for inviting me to your wonderful luncheon meeting. This is my third meeting over the years that you've had me to speak to you. As we said, this is a very controversial issue. Always will be. There will never be a consensus on this. There will always, as in the abortion issue, be people who genuinely feel opposite, that assisted suicide, euthanasia is wrong. But why should not those of us who feel that it is right proceed with law reform to have it for us who want the choice to right to die with dignity? I think the time for debating is nearly over. We've been at this subject since about 1976 when Karen Ann Quinlan case came before the courts in New Jersey. Case after case, right up through to Nancy Cruzan in recent years, when the US Supreme Court ruled that there is a constitutional right to die by the disconnection of life support systems so long as there is clear and convincing evidence. That was a 1991 case. I think it was 91. So we are making real progress. We have made a huge amount of progress in this country on the disconnection of life support systems, sometimes known as passive euthanasia. The issue before us all now is active euthanasia, active voluntary euthanasia. Is it right to help somebody to die, to do something positive to help a person? We've got to remember that living wills, powers of attorney are fine as far as they go, and I'm one of their greatest boosters. But what if there is no plug to pull? What if you are not on a life support system and yet the death is prolonged and painful and distressing and unacceptable to the patient? Therefore, you have to consider, as some people do, whether they go into a hospice. Fine, wonderful, excellent. I'm all behind hospices. But hospices don't have the perfect answer. A good hospital doesn't have the perfect answer. And the hospices and good hospitals, acute care hospitals, do a wonderful job. An increasingly better job. I think we in the Right to Die movement have jerked the medical profession into doing much better things for palliative care, and we're glad to see that. Nobody has the perfect answer, and what I am putting forward is not a perfect answer. In the Netherlands, where euthanasia is practiced and accepted and has a certain degree of legality, only 3% of the dying are assisted in their death by patients, so it's a small amount. Some die in hospices, some die in different ways, some die in their sleep. But we do need, I think, to help the people who want this option. Maybe only 3% will end up getting it or needing it, but it's a great comfort to people, especially when they've reached a terminal stage, to know that there is an escape route, that if their suffering became unmanageable and unbearable to them, they could say, I want help to die now, please, doctor. And there should be a lawful and careful means of going about this. But there isn't at the moment. In harsh legal terms, it comes down to this. Suicide is legal. Ending your life is legal. Assisting suicide is illegal, right across America, across Britain, across Europe, across Canada, and so forth. It's a crime to assist something which is not a crime, but let the lawyers work out that non-entity. So if somebody helps somebody else to die, no matter how compassionate, how deserved, how well recorded or witnessed, the moment it's a crime. The Hemlock Society and other groups in the Right to Die movement are saying now is the time to change the law to permit at least the terminally ill, mature adults to get assistance from willing physicians. And we need a whole bodyguard of protections against misuse, abuse, and so forth against that. And we've spent years, 8 to 10 years, trying to work this out. We had test runs in California with an initiative in 1988, in Washington State, just up the road, in 1991, in California again in 1992. We gathered support. 4.5 million people in California voted for Initiative 161. It wasn't enough. It was only 46%, same 46% in Washington. But we demonstrated that there was a large amount of support. More important, we saw where we were weak. And our main weakness was that we were not eliciting sufficient support from the medical profession. A great many of the medical profession have doubts and fears, and they're entitled to them. And the Right to Die movement, the Hemlock Society, Americans for Death with Dignity, Oregon Right to Die, want to cooperate with the medical profession to pass the best possible law that is there to suit patients and doctors. And I appeal to the medical profession to work with us on this. Nobody's bossing here, nobody's dictating. I mean, In Washington in 91, in California in 92, we were within 4% of passing that law without the cooperation of the medical profession. If we'd got 51%, the medical profession would have been stuck with a law which they didn't like and had no part in. Surely it would be more intelligent if they sat down with us and worked out a law that would be more acceptable. We are beginning to see that. We are seeing more intelligent doctors, particularly young doctors, are coming over to our side and are working with us to work out the bugs and the problems. The next initiative is planned for this state in 1994. The Hemlock Society of Oregon and a new coalition, Oregon Right to Die, are working out plans for an initiative in this state in November of next year. They haven't exactly decided on what law they're going to pass yet, or attempt to pass, but a great deal of work has been done. I want to talk to you about what the law, I think, should be, because this is the crux of the matter. Could I have a drink? Everything about our law is voluntary. Voluntary for the patient to request this, voluntary for a doctor or any health professional to be involved in it. There is no question of coercion. No hospital that dislikes this procedure on moral grounds has to practice it. They can opt out. Anybody can opt out of this law once it's passed. And I don't think you can say fairer than that. And they don't have to give reasons why you're opting out. They can be moral, religious, ethical, or whatever. You can just stay out of it if it is objectionable to you. It gives no new rights to doctors. They've got enough already. It gives rights to patients, the right to ask, not order, to ask a doctor to help them to die. The patient, under the Death with Dignity Act that is being proposed, although it's not fixed in this state yet, these are largely my ideas, but I think you'll find it to be broadly the same in Oregon when it comes to. The patient must be a mature adult. They must be rational. They must be competent. They must be close to death. The letter of the law says, likely to die within reasonable medical judgment within the next 6 months. Depressed people, mentally ill people, hopelessly ill people, etc., are not in this law. They are not. Only physically terminally ill people are embraced in this law. Whether it should embrace other areas of suffering is another state of the argument, another day, another fight, another controversy, another societal decision. If the patient asks for help to die and is close to death and is competent, then two doctors, the doctor who has been asked must call in a second doctor, and they must both agree that the patient is suffering, is competent, and this sounds like a reasonable request. It's all there in the letter of the law, but I'm paraphrasing for speed and understanding. We have inserted now what was not in the Washington and California laws that were tried to be passed, a waiting period. I am proposing, personally, a waiting period of 24 hours from the moment when the patient says, I want to die, to when the doctor helps them to die. Some people will argue for longer. It's something we're going to have to resolve. But I think a minimum mandatory waiting period of 24 hours is required here. I think, too, that, and this is a concession to the medical profession, which we're glad to give, there must be a signed directive, there must be a document. You need documentation in this world to avoid arguments afterwards. In the laws that I am now proposing, it's not official, but what I am now proposing, and I think from what I can tell are meeting general approval, we say that at the point when the patient asks to die, there must be two people present witnessing this request. To make sure there is no coercion, no funny business, just to say, so that they can give evidence afterwards, if called, this was a sensible require, and nobody had a gun to the patient's head. There was no coercion, no pressure. We think there should be witnesses present at the moment of request to die, as well as a written directive. You can revoke, of course, this at any time, and right up to the point when the help with death comes, you can change your mind. You can revoke it verbally or in writing. I think now, and Kevorkian, I think, has pointed us this way, and general experience and looking at Holland, we need two forms of help to die in the future. One, physician-assisted suicide. And by that, it's now come to mean in the medical profession, and we agree with this, this is the doctor giving a prescription for lethal drugs to the patient, and the patient goes home and takes their life. Now, some patients can do that, some patients want to do that. They are mobile, even though they're dying. They want to handle it themselves. A minority of patients want it that way. So we would say that there should be one method lawful where a doctor may give a prescription for lethal drugs, which at the moment is unlawful. The second way is lethal injection, active voluntary euthanasia. This is where we surround it with more protections, because it's more likely to happen in hospital with more difficult medical cases. Certainly I reject the idea that physician-assisted suicide could be by prescription only, because there are people with Lou Gehrig's disease, people with no throats or tongues, people with no stomachs who cannot swallow drugs, who need death by injection if that is what they are asking for. They cannot use the prescription method. So we have a careful set of procedures where that would be done. As I say, if this is voluntary for a doctor or a nurse to be in this field, the physician only makes this decision. A nurse would be in the periphery, I suppose, but the actual prescription or injection would be done by a physician only. But we have exempted under our law any nurse from prosecution who might be helping, holding, whatever is often necessary. So as long as the letter of the law is obeyed, no physician, healthcare facility, or health employee can be prosecuted or sued so long as the law is obeyed. If the physician doesn't want to do it, then they must discharge the patient. The patient is free to look for another doctor who might help them. This is not considered suicide. We have a clause in there under life insurance. If somebody ends their life according to the letter of the law, their life insurance cannot be cancelled or affected in any way. How much more time have I got? 2 or 3 minutes. There are penalties for pressure, inducement, coercion. It's a crime under our proposed law to force anybody into this, to forge a document, to forge a request, and so forth. So just like any other fraudulent, illegal act, there will be punishments for anybody who misuses this to try to push somebody into the grave. There will be reporting facilities. You will have to report when this happened and so forth. There will be the option for the Attorney General. If there is any funny business reported, the Attorney General will be free to conduct an inquiry into what happened. We want this, ladies and gentlemen, to be open and above board, and yet private. Death is a very private matter, but records must be kept of when it happened and to whom it happened, but those must be private. But if there is any question, then there must be an inquiry. The law that I propose would ban suicide clinics. I don't think we need that sort of thing. I think that could be wide open to abuse. Kevorkian believes in suicide clinics with 5 medical people approving before you go through. All we need is a straightforward change in the law, new guidelines, new understandings of how this should be done, and it's a private act between doctor and patient in a few desperate cases. This is an idea whose time has come. Let's all sit down and work out how it will be done. Improve on my ideas. Fine. Thank you very much.
Thank you, Mr. Humphry, and now we'll hear from Dr. Tolle.
Rather than focus my remarks on why we should not legalize euthanasia and assisted suicide, which I oppose, as I have previously shared with this group. I will focus on changes we can legally make which will enhance the comfort and control of all dying patients. I'm against the status quo. What we do now all too often leaves patients suffering. It's estimated that about half of people who are dying in the United States have inadequate pain management in the process of dying. And many who are making efforts to refuse life-sustaining treatment, machines, intensive care, sometimes don't get those refusals acknowledged as quickly as they should be. I am against legalizing euthanasia, and I think that the approach that Mr. Humphry is taking is far too narrow. As he acknowledged, the focus of his efforts are for 3% of people. Therefore, those few people, for example, in the Netherlands, who elect lethal injection or assisted suicide as their means of dying. Now, I will grant that others would like it as an option, but that very few people actually utilize it, and yet huge numbers of people in this country have their needs inadequately met in the dying process. Too many of you have seen someone suffering while they're dying. Too many of you have seen people under-medicated or over-treated and want more control in the dying process. And I think that's part of the reason that people vote for initiatives like euthanasia. But often when I talk to people, including a number of you before this meeting started, I want to be able to refuse things. I want more control. But no one said to me, I want to be killed. And I'm struck by the fact that some people do want that, but that most people want something else and we're not giving it. We need to shift where the control is for terminally ill people. From physicians tightly controlling certain decision-making, certain education about what's likely to happen, carefully metering out narcotics often too little, to more control for patients and their families. I'd like to focus on control, comfort, compassion, and communication, all of which need to change. Particularly the issue of control. People need an easier way to make it clear that they don't want certain things done. Senate Bill 286, Oregon's new laws about living will, power of attorney for health care, make it a little easier to say what you want and don't want. They use more lay language, they make things a little more understandable, and a few more people will probably fill them out. But the bigger issue is control about pain medication. And all living will statutes throughout the United States make reference to your ability to refuse treatments, but they don't make reference to what you get. And I think it's part of the reason people have sometimes been reluctant to fill them out. You don't get machines, so what do you get? Nothing? Does that mean you're abandoned from health care? And in Senate Bill 286, for the first time, clear statements are made about what you do get. This bill says, shall provide medications to relieve pain and suffering. Shall provide, not may provide, it's may now. We may do it, and we do it about half of the time. But now families will be much more empowered to demand adequate pain medication. It's their right once the governor signs this. It may bring about some significant changes. It's going to take more than that, though. It's going to take better communication. We often know something about the natural history of what will happen as a patient is dying. For example, if someone has lung cancer and is crowding the airway with the cancer and is having more difficulty breathing, we will give them some narcotics, morphine, and some tranquilizers, cousins of Valium, that will make that sense of struggling to breathe not as bad. But as it gets worse, and maybe it'll get worse fast and suddenly, it would be unusual for us to talk with the patient and say, this is likely to happen to you, and here's how much more of the morphine you should take, and how much more of the other tranquilizer you should take to be comfortable right then, and then call and find out how to continue to meter out the dose appropriately so that immediately your symptoms are relieved, telling the patient and their caregivers exactly what to do for what's likely to come. Now, we can't predict everything, but that's a real shift in control if you knew and had the means. It means you have to give more medication too. Not just a little tiny bit, but enough on hand so that a change in condition could be responded to immediately. Or another patient who has breast cancer with metastases to bone, and with any changes like a deep cough might fracture a rib. Enough medication on hand and information about that so that they could move up the dose substantially right away and stay on top of their pain and suffering. That's the communication and the shift in control and the empowerment that we need to bring about much more humane care for everyone and much more control for patients, which I believe patients are asking for in this initiative about assisted suicide. Give me some power to control what may be too horrible. We could do that now. What is the downside of that? Well, patients will certainly be more easily able to stockpile medications and to take their own lives. If we're going to give them what they need to respond to an urgent situation at night or on the weekend and they have adequate supplies, they will have more of the medications to easily end their lives. But we have to ask questions about why physicians are so worried about that. Why don't physicians give more medication? Why is it that about half of people who are dying have inadequate control of their symptoms? Is it because we don't have the technology? No. We can control pain for almost anybody at a cost of maybe fairly heavy sedation. But we have ways with patches, with IV drips, with all kinds of ways to deliver medication to meet the needs of physical pain if we used it. So why don't we use it? Are we afraid of addiction? That's not the real issue, I don't think. Are we uncaring? I think sometimes we don't ask enough questions to really know how much pain somebody's experiencing. But I think that's not the issue either. I think we're afraid. We're afraid of criminal charges. We're afraid that if we give enough medication to someone who's dying, we may shorten life. We know that if someone is months away from dying and we give them adequate medication to relieve their symptoms, they probably sleep better, eat better, and live longer. But in the final days and hours, when someone's pain may be fairly severe, if we give the high doses that are required, they don't cough quite as well, they get pneumonia more easily, and they may live, and in some cases they do live, less long if we do it well. And we're afraid of accusations, of criminal charges. Even though no one has ever been convicted in the United States, I think it's what frightens us. And that's where legislation like Senate Bill 286 that says shall provide medication to relieve pain and suffering may help anxious, frightened physicians do what they need to do in prescribing the right amount of medications to meet the needs. The Board of Medical Examiners last year sent letters to every physician in the state, talking with them about appropriate pain management for dying patients. And in that letter, they said that even if blood pressure is falling, even if respirations are decreasing, that giving medication for pain and suffering was appropriate. What that means is that even if high-dose pain medication shortens life in somebody who's very actively dying, that the Board of Medical Examiners says our goal is to treat the symptoms and care for the patient, and acknowledges that sometimes they may die a little sooner. What we need is to shift our focus. Our focus needs to be on comfort and communication, not policing narcotics to be sure somebody doesn't kill themselves. I don't think that if we change this focus, that the number of people who kill themselves is going to go up. I think people who really want to, do it now and find a way. And I think some of the people who kill themselves now do so because they have such inadequate control of their symptoms that they're desperate. And perhaps some of them won't if we do things differently. I think our goal needs to change. It needs to change to relief of pain and suffering as determined by the patient. Now it's as determined by the physician most often. Some patients want to be as awake and alert as they possibly can. They want to write a last book chapter. They want to have a meaningful conversation with a family member. And others say, in the last day or two, I want to be heavily sedated. I want to be out of it. It's too horrible. Can we let them define the appropriate level of relief of pain and suffering so that there isn't the terrible fear that they will die like someone they've seen, writhing in pain, and know that we will be there for them? I'm against legalization. I think legalizing deliberate efforts to kill people, lethal injection, does not meet the needs of the majority of patients for increased control and is dangerous policy. I'm even more concerned than the last time I spoke before this body because of the changes in healthcare reform. As we look at managed competition and increased emphasis on economic issues, I think those pressures can be quite coercive, and they can be coercive on a dying person to potentially elect the option of assisted suicide or euthanasia in a way that the Netherlands doesn't have to deal with. I think we need to focus on comfort and compassion, and if we do it in a way quite differently from the way many physicians have done it now, we will meet most patients' needs for control in the dying process, something we desperately need to do first. Thank you. I welcome your questions.
Thank you, Dr. Tolle. Now it is time for questions to our speakers. They will be taking them from the head table. Please indicate whether your question is to one or the other or to both of them. And please also make your questions brief. Try to get to the question mark part of your question as quickly as possible. Again, for the first question, Dr. Franz Storrs.
Well, I certainly thank both Dr. Tolle and Mr. Humphry for their remarks. They were very helpful to me. I would ask both of you, Dr. Tolle initially, help me understand as a patient, really, not as a potential patient, not as a physician, how the passage of this new bill, Senate Bill 286, is likely to really change the practice of medicine as we understand it right now. What will it really do to the day-to-day practice? And I'd be interested for Mr. Humphry to tell us how the passage of this bill is likely to change the strategies, the political strategies of organizations of the sort that he's involved in.
Senate Bill 286 is awaiting the governor's signature, and when and if signed, would change the practice of medicine fairly radically. It will not change much who life support is withdrawn from. I think that there will be continued thoughtful withdrawal of life support, and I'm not sure it will be a lot sooner than it is now. But I do think very fearful physicians, and there are lots of us in that category, will feel more comfortable giving appropriate levels of medication. And I think it will greatly change the practice of those last days of terminal care where adequate pain medication will much more frequently be given?
I don't know much about this particular piece of legislation, and I blame the media. I live in Eugene. I have not seen anything. I'm a great newspaper reader and watcher of news programs and feature programs. I drive my wife mad with it. I've not seen a word on this bill. I know almost nothing about it. I don't involve myself deeply, professionally, in living will, power of attorney. I take an interest in it, but I don't involve myself in it. But just as a member of the public, the media has failed me completely. I've not heard about it. So I bow to your superior knowledge, much superior knowledge.
Gary Harrell, City Club member. My question is for both of our speakers. A few weeks ago, Senator Shoemaker and the governor's aide, Roger Arbach, spoke to this audience on the importance of the public meetings process run by Oregon Health Decisions in the development of the Oregon Health Plan. And I'm curious what role you think a similar public meetings process could play in clarifying public values on this issue of physician-assisted suicide.
Well, our experience in Washington and California with public meetings is that, yes, they're good, and you get some media attention, which of course takes the subject out into the homes for newspapers and television, but they are mainly attended by people with views are already firmly fixed, and they come to air those views. I've never got I spoke at scores of public meetings on political fronts. I never got the feeling that we've convinced or changed the minds of many people. But they're worth having, and I support them.
I think the public meetings process can make a powerful difference, because if Senate Bill 286 is passed, then I think letting people know how much more a sword and a shield is what it will provide as far as pain medication. The sword, the lawyers call it, in the hands of the family, empowering them to make requests appropriately for pain medication, and a shield for doctors providing enough. And I think as more education arises around this, people can sort out what is left unmet, because the unmet needs shouldn't be the suffering patients. In the Netherlands, people who use euthanasia are not people who are suffering physical pain primarily. They are people who have symptoms we can't treat. And let's talk about those remaining people then in a more focused way when we've taken care of all the other issues. They're the 65-pound advanced AIDS patient who has lost bowel and bladder function, who has a weeping wound that smells foully. Those are the challenging patients where all of the things that we need to change now, and do change, I hope, very quickly, will still leave us with some unanswered questions, and that may be the person who stockpiles and takes their own life.
I was kind of stunned listening to you people, because it reminded me of the last 10 seconds in a ball game that usually takes 10, 15 minutes to finish. You talk about all these complexities and everything, and yet Dr. Kevorkian seems to do what one of you is advocating, and a state legislature doesn't seem to much stop him in arrest. And it reminds me of what a coach said to a player once who was in a bad slump. He says, look, just quit trying to read the trademark and just kick the damn thing. Isn't this really the problem? It's that you just have to go do it and just quit the talking, because Kevorkian doesn't seem to have all of these problems.
Because very few doctors want to be in court, risk prison charges, have expensive lawyers looking after them, have the media hounding their every move. Dr. Kevorkian is a very unusual man. He's a maverick, a loose cannon. I think we need Dr. Kevorkian. The attention he's drawn to. But not a single doctor in America has followed him. There's, 700,000 doctors in this country. They do it discreetly, quietly. Euthanasia goes on all the time. They do it quietly and covertly for certain of their patients. He's a very unusual man. Other doctors are not going to follow his example, even in the most extreme compassionate cases, until we change the law on assisted suicide.
I think we don't want Dr. Kevorkian here. He is someone who has no relationship with the patient. He has no special training in pain management. He has no special interest or training in dealing with issues of depression. He is not what patients need when they're dying. And the fact that his actions would be illegal here is what I think we want to continue.
But any port in a storm. We got to give him credit for that.
I'm Herb Crane, a member, and my question essentially is directed to Dr. Tor. Did I say that right?
Tolle.
Tolle, excuse me. It seems to me that you expressed a great deal of compassionate concern for the physician forced to make a decision which might in turn come back to haunt him in the courts or in other ways. But I heard nothing to the extent of your concern for the physician, for the concern of the patient. I lost a wife 2 years ago, dreadfully to cancer. And I can't believe that anyone, any ethical person could impose his or her ethics on that of a patient. Can you deal with that?
You're right. The focus needs to be on patients and increased control for patients. I tried to share why I thought it was not, which is physician fears. But you're right. Patients need more control. They need more respect. They need more choices. They need more comfort. And they need to set the level of comfort themselves and make choices for themselves. And yes, some will choose to kill themselves. And I say my job is much less to police that than it is to make sure that your wife or any other person is much more comfortable.
Bob Shoemaker, member. As we talk about moving to aid in dying legislation, it seems to me we sort of shift from a right to die possibly to a duty to die. And I'm concerned with the implications of that and the guilt that that imposes upon the dying person, and also the effects of that on the family of the dying person whose motives may not always be the most honorable. And then, of course, after the deed is done, a lot of guilt then floods in on the family. So I'd be interested in both of your comments on that concern.
Well, in those cases where there is guilt, I have heard and seen and observed as much guilt with the disconnection of life support systems, which you, Dr. Shoemaker, fought so nobly for, as in assisted suicide. People agonize over whether they should have permitted the pulling of the plug, as with providing the drugs in assisted suicide. In some cases, it's usually tied up with grief and so forth. So it's a more complicated matter, but I don't see how you can say it amuses me how all this, we must be careful, the depression on assisted suicide. I don't hear of any, what about depression of people who want the plug pulled or depression? You're setting a much higher standard for us. We don't mind, we'll take it. You've set a very poor standard, you in our health choices and living wills, for the depression, testing and guilt of the disconnection of life support systems, which is just as serious because it ends life in difficult circumstances. You can't have one standard for my side of the argument and one standard for yours. It must be a high standard for both.
I do think that there is a difference between what families experience in the withdrawal of life-sustaining treatment and what they experience if they deliberately, actively assist someone to shorten the period of time they would have had. But the biggest difference you end up seeing is if they are absolutely sure what the person wanted. The anguish that you see in withdrawal of life support is usually that there wasn't communication within the family, and while it's relatively hopeless, the loved one never said to the family members, When it's hopeless, I want you to quit. And they agonize then about having withdrawn life-sustaining treatment because they didn't have the firm assurance from the person that they were doing the right thing. So Mr. Humphrey's right. Sometimes people can agonize over withdrawal of life support decisions, but it's usually because there weren't good communications within the family, or there wasn't good communication with the healthcare team, and it mixes in with their other issues when it really was relatively hopeless anyway. Because if there's equivocation in those circumstances, and there's any reasonable hope that something meaningful may be done, life-sustaining treatments are usually continued.
Ray Polanyi, a City Club member. I have a question which probably either one or both may want to answer. I'm thinking, before the world got so much more complicated, and before we got so much more malpractice around, wasn't there a time when family doctors, on occasion assisted in an earlier death, without fanfare, without much discussion? Would you care to answer that?
I'm sure that for all time, as long as we have had the kinds of narcotics that we have now, that there have been times where patients have been given fairly high doses. I'm amazed as I talk to older physicians about how sometimes when they have these conversations, it's hard to tell what they meant for sure when they said they helped someone along. Often they meant they stopped the ventilator and they somehow thought that was helping them along as the ventilators came along. Many times physicians agonize extremely when they give the high-dose medication that they believe shortens life, and I do too in some circumstances, and I think it's the right thing to do. But they say, well, I helped them over the edge. And they have, and they do. And I'm arguing that there are times where in compassionate care, aiming at symptoms, that's the right thing to do now. And openly and above board. But when we talk about openly, we have to be very careful that we don't drag some poor family into some major public media event in the process of bringing about change. I think that there have always been doctors who quietly gave more than is being shared here.
Ned Luck, member. I have two concerns. I have a concern about the cost of long-term care. I have an equal concern about the cost of long-term care insurance that many families take so that what financial resources they have are not depleted during the course of the illness. I don't see why, one, I've got to take insurance to make sure that I get long-term care that I don't want. I want to have the option when I'm faced with long-term care to on my own, in my family, make a decision that we've had enough and we don't want to deplete the fortune what financial resources we have, nor do I want to find myself with the prohibitive cost of long-term care insurance. I wish you could both comment on that.
Well, I think it's tragic that people in this country, and not in some countries in Europe, feel pressured to make decisions about ending their lives based on cost. That it's going to bankrupt the family to cover the cost of long-term care. That's the kind of pressures that I think make policy decisions around assisted suicide and euthanasia particularly dangerous in this country, because we have these enormous prohibitive costs that can bankrupt families to care for loved ones. And if the issue's money, not the indignity of a nursing home, and the one you brought up was money, then I think we have a huge issue to deal with, and all the more reason to fear legalizing euthanasia if the prohibitive costs are the reasons people are going to seek to have assisted suicide. Now, that may not be what you meant.
That's why I came back to the microphone. What I meant is There's many of us who do not want to continue to live under the circumstances that we need long-term care.
Yes.
We have lost the joy of living, the meaning for living. We are a burden to our family, and we're a burden to ourselves. And I want the decision to be mine, not anybody else's, once I've considered my family and those concerns.
The issue of advanced Alzheimer's is one that you're, among others, addressing. And none of the proposed legislation touches that issue either. That the issue of people with Alzheimer's, they become incompetent, they no longer qualify for signatures, et cetera, or they're way early in their disease and they're not terminally ill. We do address the issue of their ability to refuse treatments, including refusing tube feedings more effectively in the new legislation, and life support for those people. But that's different than moving the clock way back for people like Janet Atkins, who find the whole process of Alzheimer's abhorrent. I don't think Mr. Humphry has an answer, and I don't, to the tough choices of advanced Alzheimer's patients and protecting vulnerable people in that circumstance, other than assuring that the family is not bankrupted in the process as we do now.
I think that the legalization of voluntary euthanasia, which I think is not too far off, is going to jerk the medical profession into this century, into better pain control. We've already achieved a good deal of that, taking more better trained doctors, better pain control. I think it's going to jerk the health care insurance industry into looking at it differently. So if it takes this new law to bring about reforms and rethinking, then I welcome it, and I think most reasonable people would.
Dick Wise, excuse me. Dick Wise, a member of the City Club. My question is to Dr. Tolle. Early in your talk, you emphasized the need to give patients more control over their medication. Mm-hmm. This, to me, is an affirmation of the concept of personal autonomy. And if you are willing to concede that an individual has the right of personal autonomy to control his or her own destiny, with respect to pain-killing medication, which may accelerate death, why are you denying the right of personal autonomy to choose an accelerated death?
You bring up a very challenging question for medical care, and one that we struggle with as we try to figure out how much more control can we give and should we give. I'm a strong advocate of much more autonomy for patients than we give now in all kinds of arenas. For example, I see no reason why you can't read your medical record. You can't have who you want in the hospital with you for dinner. That you can't have someone join you in a procedure in the hospital because it's more reassuring for you to be there with them. And for you to know what your medications do, for us to be honest and upfront about your medications and answering your questions honestly, and not be patrolling you so carefully and worrying so much about whether or not you'll kill yourself, but rather making my job the major focus on your comfort. And if I really focus on assuring that you have what you need and not, are you going to kill yourself and I must stop you, it's going to be a very big change. It may not be as far as you'd want to go, but it's a huge change in healthcare to give that much control and power and information to you, to titrate the doses and have supplies on hand.
Gray McReynolds. In a Gallup poll in July of 1991, 9 out of 10 individuals said that if they were terminally ill, they would choose care that kept them at home, addressed pain management, treated not only the individual but the family, and provided social, psychological, and spiritual services. Unfortunately, the poll also revealed that very few people know that these services already exist. It's called hospice. Where does the choice of hospice enter into the physician-patient communication, Dr. Tolle, and further, Mr. Humphry, into any proposed legislation?
Well, I think it enters in extremely early in this dialogue and was underemphasized in my presentation today as I'd shared it before. But we often don't tell people all of their options. You can refuse life-sustaining treatment. Here are forms. But not the affirmative side that people have needed so much. Here is what can be done. Here's what I can do for you. Here's what you can do for yourself. Here are various programs and supports and means to better meet your needs, among them hospice, which I think very highly of.
As I've said, I'm totally in favor of hospice as well, but you asked specifically about the law that I'm proposing. Item 1.4 says, pain control and alternatives, no request for either form of physician-aided dying shall be acceded to unless all reasonable pain control techniques and other alternatives to dying have been offered to the patient and have been declined as unacceptable.
We have time for one more question.
We all know that the debate over abortion over the last 2 decades has been a fundamental cultural divide and has recently almost become a violent civil war with guerrilla groups going out and murdering their opponents. And yet I see the two of you sitting up there on the dais debating this in the rational, measured tones of a university discourse. I wonder if you think that society is going to address the issue so calmly as you just have.
Ted, I don't think so. But I think the kinds of discourse that are needed are the kinds where people talk all the way to the boundaries of what can be done, what can we change, how can we better meet patients' needs. And I do think that there has been some useful benefit to all patients from the initiatives about aid in dying. It's been a wake-up call to the medical profession. And I think we needed it about the issue of pain management and listening to people refusing medical treatment.
I agree.
Mr. Humphry, Dr. Tolle, on behalf of the members of the club, we want to thank you very much. Very thought-provoking discussion here this afternoon. We're adjourned.
Thank you very much for doing this, Susan. And Mr. Humphry, thank you so much for coming in.